All right. So, welcome to The Life of Her Mind, a Lab Roots podcast devoted to learning how women think about their research, their fields, and their future. My name is Mia Wood. I'm a philosophy professor with over 20 years of experience working at the intersection of philosophy and, well, everything else. And I'm particularly interested in the sciences. My guest today is Dr. Kellie Smith, Associate Professor of Oncology in the Bloomberg-Kimmel Institute for Cancer Immunotherapy at the Johns Hopkins School of Medicine. Dr. Smith has developed an original assay for detecting anti-tumor immune responses in specific types of lung cancer. Among other topics, Dr. Smith will tell us how she developed that test and a new test called MANASCORE, and share some details about the goal of comprehensively understanding immunotherapy-resistant immune cells. Welcome, Dr. Smith, and thank you.
Thank you so much for having me. It's a pleasure.
Oh, good. I'm glad. All right, so let's get started. Can you tell us how you came to study science and then specialize in T-cell immunology and immunotherapy?
This is actually a long and interesting story, so I will keep it very brief. I originally wanted to work in physical therapy. That's kind of what I wanted to do since I was a very young teenager, after a physical therapy experience I had as a young person. And I started working in the field and I realized that it kind of just wasn't for me. It takes a very special person to interact with people who are in immense amounts of pain. And that was not I was not cut out for that. Let me just say that. So I started thinking, what can I do where I can still make a difference, but I can kind of work behind the scenes a little bit. And I had this very formative experience in undergrad where I had to read this book called The Coming Plague. And we were assigned to pick a chapter, and each chapter was a different human plague, essentially. And then we had to write a report on that chapter. And of course, being the overachiever, I picked the biggest chapter, which was HIV/AIDS.
Mhm.
And I just became enthralled with it, with the socioeconomic implications of it, all of the things that were going on in the 80s with these patient populations that were affected by the HIV/AIDS epidemic.
Mhm.
And I decided that I wanted to do HIV research.
Mhm.
So I applied to graduate programs and I was accepted at the University of Pittsburgh into their virology program. And I just kind of happened to stumble into a lab that was doing immunotherapy for HIV. And that's kind of how I started the path in immunology. I really had no intention of going into immunology, but I really just wanted the HIV aspect. And it was just kind of happenstance that the lab I joined was really heavy in immunology. And that's kind of how I fell in love with immunology.
Okay. So yeah, sort of luck in some sense, and falling into it, and being ambitious, as you say, when you picked the most difficult chapter in that book back in high school. So then, what brought you after you finished your degrees? What brought you to Johns Hopkins, and how is remaining at that institution for a good period of time facilitated your work? How's it been an asset to your research?
This is another interesting story as well. So when I was looking for a postdoctoral fellowship, I really wanted to stay in the HIV field. I just really enjoyed it. I wanted to stay in HIV immunology.
Mhm.
And my husband and I both, we were both from Baltimore originally. We wanted to be in Baltimore. And I wasn't really finding any positions that really spoke to me or that were really exciting to me.
Mhm.
And someone that I was working with at Pitt said, there's this guy at Hopkins, Drew Partle, he does immunotherapy for cancer. Why don't you email him? And I'm embarrassed to say at this point, I had no idea who he was. He is, one of the most famous cancer immunologists in the world.
Mm.
So I emailed him and he actually read my email, which, when you email these very famous scientists, sometimes it takes a few times that
Yeah.
before they get the email. He actually read it, and it turned out that he was looking for someone to do in cancer what I had been doing in HIV, which was
Ah.
sequencing the patient's own virus and making antigens that are specific for that patient's virus and testing their blood for responses against their own unique virus. And Drew was looking for someone to do that for cancer. So he wanted someone to sequence their own tumor and then test their blood for responses to their own unique tumor antigens. So it really was just another thing of happenstance that I wound up in Drew's lab as a postdoctoral fellow. And as you hinted, I have not left since. And that really is what happens at Johns Hopkins is kind of once you come here, you fall in love with the place, you fall in love with the work. I absolutely loved having Drew as a mentor. And I wanted to stay. And I think staying here has benefited me immensely in my career because I now have this vast community of people all across the university that and who study many different disciplines because cancer is it's interdisciplinary. It's not just immunology, it's not just cancer biology. So it really has allowed me to do a breadth of work that I don't think I would have been able to do if I kind of hopped around to different institutions.
Mm-hmm. And so can I piggyback off of something that you mentioned that struck me, and then maybe also if it's doable, connect it to what you just said about the sort of the breadth and depth of connections that you have when you remain at an institution for as long as you have. It's this idea that really hadn't occurred to me that okay, so let's say we've got this one virus, HIV, but when you're testing an individual patient, there's a sense in which what I'm hearing you say is the test is sort of gives you custom information about that patient. And because my first thought would be, oh, well, everybody with this disease is going to effectively look the same way. Isn't that how therapies get developed that are successful? Not so, apparently. And then, so how does that connect with respect to your work in specific types of lung cancer? And then, there's obviously got to be some creativity in your thinking about this and how you interact with your colleagues across disciplines.
Excellent question. So this was also something that was very surprising to me as someone with a PhD. When I started in cancer, I thought not only are all lung cancers the same, I was thinking, molecularly, all cancers are really the same. They're all the same. And not so. Just like every patient's HIV virus is unique to them, every person's cancer is unique to them. And that's what really makes it a very challenging thing to study and to develop effective therapies for. And to address the issue of how do we study something that is so different between patients, that's really where some of these tests that our lab has developed have come into play. So the manifest, for example, really was developed when I was a postdoc. And I was having a lot of trouble detecting these responses in cancer patients. And I was working on patients with lung cancer. And lung cancer, after the first immunotherapy studies, we know that in some patients, lung cancers can be very immunogenic. So it was very shocking to me that we were testing the blood of these patients, and I could not find any T cell responses, even in patients who responded very well to immunotherapy, using these conventional methods that we've used for decades. So that's why we developed the manifest assay, which allows us to test the unique antigens that are present in that patient's tumor. And the readout is using sequencing of T cell receptors rather than production of cytokines. So it's a much, much more sensitive test than like interferon gamma ELISpots, which have been used for 2+ decades now. So that was kind of why we developed this test, because we were thinking, there has to be a T cell response. They're responding to immunotherapy.
Mm.
Why can't we detect this response?
Mhm.
So we developed this test, and we were able to use it in lung cancer patients who were being treated with immunotherapy. And in fact, we were then able to detect their T cell responses in the blood.
And then when that happens, is it is it the case that the therapy is effectively adapted to or customized to that patient so that you get the response, you get the immune system to do what you want it to do in that particular case? I mean, I know that's the clinical side, but is that a fair question to ask?
It absolutely is.
Okay.
And this is really where the field is heading. So
Oh.
we started off with chemotherapy, right? So it, 2 decades ago, you give everybody chemotherapy when they get cancer,
Mhm.
right? And it is not personalized. It is not it's just everyone gets chemo. But as the field has evolved, we've realized that again, every person's tumor is unique. There are shared features between some people, like some people have common mutations, or some tumors have common mutations in them. And some tumors express PD-L1, and some of these patients have PD-1. So those are the cases, where checkpoint blockade might be effective. Really, where the field is going now is more precision immunotherapy or precision drug targeting. So if we can treat all tumors that have a KRAS mutation, for example, if we can develop a drug, which there are drugs now approved, that inhibit KRAS, that is kind of getting at the personal nature of these tumors
Mhm.
without having to develop a unique therapy for every single patient.
Ah.
Now, the third option, so we have kind of the global targeting strategies, which are chemo, immunotherapy, that sort of thing. Then we have precision targeting, which is targeting things like mutations that are shared between different cancers. We also have personalized approaches, and this has really been evidenced by neoantigen vaccines that are being tested. So basically, we generate a vaccine that is unique for each patient's tumor and each patient's mutations. And then you give them this vaccine to kind of boost the anti-tumor immune response to that patient's own cancer. So that is, of course, the most work involved, but it is going to be the most precise and the
Mhm.
most personalized.
Wow. So when you talk about 20 years of this work, as it turns out, my dad died 21 years ago from lung cancer, and that's what we did. It was the chemo and the radiation. So so initially one of my questions, and maybe it still does apply, but one of my questions was, when I think about scientific work, I think about this, incredibly sustained and just detailed dedication to work that may not pay off for like decades, let's say. But what you're saying is that this field is developing, maybe by contrast, to other scientific areas of study and research, a lot faster. So does it always feel like you're, oh my gosh, we're making progress? Or is it still the case that, you've got your nose to the grindstone and you're just being patient?
Yeah, I will say over the last few years, it has felt more of the grindstone.
Ah.
So it has been more of a game of inches rather than a game of miles. We often in the field talk about finding the next PD-1.
Mm.
So when anti-PD-1 was really, there was a lot of excitement about it. We were seeing complete responses, dare I say the word cures, in patients. And I think it's safe to say now that we have seen cures. So these patients were treated, some of them in the early clinical trials in like 2010, and
Mm.
they're still cancer free. So I think
Wow.
at this point we can say cured from metastatic cancer. And we really are kind of looking for the next PD-1. But I have to say, I don't think that's what it's going to be. I think it really is going to be these incremental advances. where we delve more into the precision immunotherapy approaches. I don't foresee something new coming on the market that is going to work across tumor types. I think really what we're doing now is getting into the weeds and say, okay, what if we look at tumors with shared features?
Mhm.
Is there some drug we can develop for those patients that have that tumor? And I think that is really where the success is going to be over the next 5 to 10 years.
And is it fair to ask what what brings you to that conclusion?
Yeah, I think it's just the nature of the beast. I don't know necessarily that we're gonna find something that, chemo was great for what it was.
Mhm.
And we still use chemo. Most patients now who receive immunotherapy receive it in combination with chemotherapy. And it was great at working across a broad range of patients. But I think the field is of the feeling that if we want to improve upon immunotherapy, which improved upon chemo, I think the next step really is going to be what is unique about these tumors and can we target them?
Okay. Um, so I want to, we could stay in that area for forever, but I want to make sure that I ask you what I take to be kind of more um, intellectually personal, if that makes sense. So what for you is the most exciting part of doing science?
I would say twofold. So, really, one exciting part for me is getting to mentor younger scientists.
Mhm.
It really is nice seeing how excited they get when they get a piece of data,
Mm.
um, and how engaged they are, and how much you are able to mentor and guide them not only as a scientist but as a person in the world and navigating science in the context of our world. That is really rewarding for me. The other thing that I think gets lost on a lot of scientists is that when you make a discovery, and most discoveries are not eureka moments, it really is, what, or that doesn't make sense, or are you sure you did that right? And it's weeks or months or years of kind of like figuring something out, and then when you put it all together, you're like, wow, this is really something. But no matter how big or small the discovery, for a moment, you are the only person in the world who knows that thing, who knows this piece of information. And I think that is something that is really special about science and is lost on a lot of people. And I think we get hung up in the publications and the grants and trying to make a name for ourselves. But really, it's can we make a difference for patients? Is what I'm doing important? Does it have the potential to improve the life of someone with cancer?
Mhm.
So that's really rewarding. But also there's this moment where you're the only person who knows this thing, and that's really cool.
I've never, so it reminds me of these ideas, both Plato and Aristotle talk about, philosophy beginning in wonder. And those moments where that you're talking about where it does become clear that you're onto something and that, to then have it confirmed, right, is terribly exciting for the reasons that you mentioned. But we love to learn, we love to know. And that is a wonderful motivation. It's very exciting for us individually. So thank you for that.
Yes, absolutely.
Um, all right, so maybe piggybacking off of that, what are the first words that come to your mind when you think of the word scientist?
Truth, I think. Truth seeker. This is really what we do,
Mhm.
and sometimes it gets lost, even if the truth is contradictory to what we expect
Mhm.
or what is convenient.
Mhm.
It really is the search for truth. And that, I think, is one very important thing that we have to constantly remind ourselves of, is the truth is not always going to be what we thought it was going to be. Our hypothesis is not always going to be proven correct, and that's okay. That's part of science.
And does it feel, maybe that it doesn't feel like this from day to day, but are you comfortable with that uncertainty? In other words, scientists say effectively, look, this is the best understanding we have right now, or it may be the most understanding that we can ever get. Who knows, right? But that, the truth, if things work, they're true, but we're ready to revise and amend if we need to. I mean, that sort of uncertainty seems hard for some people to live in. But it sounds like you're very comfortable with what I'll just characterize as like provisional truth.
Correct. Absolutely. And this is where ego, I think, comes into play. So I always tell my lab and my trainees, in science, there is no room for ego. There's a lot of it. There's too much of it, I think. And if we want to be open to the fact that our findings might be disproven, and that's okay, we have to get rid of the ego. That's very, very important. And I think part of this too is from the perspective of, I guess, job security and self-preservation, we should be asking questions that, even if our hypothesis is wrong or is disproven, the answer is still interesting and is still important. And so I think that's where the scientific method and the training process of up-and-coming scientists is really important, is pick your questions really wisely. Not to say there isn't value in the big questions, the high-risk questions, where if it's true, it's awesome, and if it's not true, it really sucks. That there's importance in that too, and there's value in that too. But obviously, you can't base an entire career on that, because it's very risky. So it really all comes down to, what are the questions you're asking, and in what ways are you asking those questions, so that if your hypothesis is disproven with your experiments, is there still an interesting path there that is meaningful to the community?
Okay. You've mentioned that sentiment or view a couple of times about, benefiting the community or of patients, or benefiting humanity at large. Do you have any advice for people who may be at present kind of nervous about pursuing work in the sciences because there is so much uncertainty over, funding and priorities?
Yeah, I think in terms of the funding, there is a lot of uncertainty, and I wish I had a more optimistic outlook or some more words of encouragement. Given that we're at the end of the government fiscal year, heading towards a shutdown, we have no idea if there's going to be NIH funding. Thankfully, there are a lot of philanthropic organizations who have stepped up over the last couple of months and have committed to increasing the grants that they're awarding for research. So that has been one really encouraging thing about all of this. And I think the second thing is that not all scientists have to end up in academia. The non-academic positions are not dependent on grants. So I think, trainees should not be deterred by the current situation. I think more so, this is maybe a little bit tangential to what you're asking, but I think more of a concern right now is just the general distrust of science in general. And I have to say, the scientific community, I think, has to own some responsibility for that. I think, the way that we interact with non-scientists matters.
Mhm.
And I think taking concerns seriously, even if they come from a source that we don't like or a source that we deem is not educated enough, I think taking the concerns of the public seriously and coming at it from a data-driven perspective
Mhm.
and saying, okay, let me actually take this issue seriously. Let me look into the data and see what it actually says. Let me not dismiss these concerns.
Mhm.
I think restoring the public's trust in science is really important now. And I think we have to take some ownership over that process.
Well, and that also dovetails, I think, with your point about ego, which is, look, it's possible I'm mistaken. Let's see what the evidence shows and then make a determination based on that. Yeah.
Yes, absolutely. And I think, a lot of scientists and physicians, they come from families of academics or scientists and physicians. So sometimes this can get a little lost, but,
Mm.
I'm the first person in my family to go to college. Most people in my personal life are not scientists. They never went to college.
Mhm.
And I can tell you that the concerns that the general public has with scientists are real and they're
Mhm.
sometimes valid.
Mhm.
And when they raise a concern and they're kind of shrugged off and
Mm.
told that it's a conspiracy theorist or you don't know what you're talking about, that really breaks down the trust that people have in what we're doing. And it really harms legitimate science that's being done.
Mm.
And it facilitates more of these conspiracy things to make their way
Ah,
into general practice.
okay. Well, thank you for that. That's my goodness. I would love to press more on a number of issues that you've raised, but I know your time is valuable, and I want to thank you for taking time to chat today. And I'm hoping that maybe you'll come back again.
Absolutely. Thank you so much for having me.
Thank you. Thank you to Dr. Kellie Smith for sharing a bit of the life of her mind today on the life of her mind. I'll look forward to seeing you next time when we interview Dr. Veena Joy, the U.S. Autoimmunity Lead for Medical and Scientific Affairs at Thermo Fisher Scientific. Meanwhile, visit labroots.com for all sorts of interesting things like virtual events, webinars, and trending news.